This presentation is about anticoagulants. Anticoagulants are used in the prevention and treatment of thromboembolic disorders, including DVT, pulmonary embolism, and atrial fibrillation. They may also be used in the management of myocardial infarctions. The therapeutic use of anticoagulants is to prevent clot extension and formation. Anticoagulants are used to prolong bleeding time and thereby prevent thrombi from forming or enlarging. During this presentation, we will discuss heparin, heparin-like drugs, vitamin K antagonists, direct thrombin inhibitors, and factor XA inhibitors. The first prototype drug we will be discussing is heparin. Heparin works by initiating an inhibitory response to antithrombin on thrombin and factor XA, thereby preventing clot formation and/or the extension of existing clots. Heparin is used in the prevention and treatment of thromboembolic disorders such as venous thromboembolism, pulmonary emboli, AFib, and/or acute and chronic coagulopathies. Used in very low doses to maintain patency of IVs, heparin works by stopping the conversion of prothrombin to thrombin through its effect on factor XA. When given in higher doses, it neutralizes thrombin through stopping the conversion of fibrinogen to fibrin. Some major side effects include drug-induced hepatitis, hair loss, rash, hives, bleeding, anemia, pain at the injection site, osteoporosis, and fever. When administered intravenously, the safe dose ranges from 5,000 to 40,000 units. When injected subcutaneously, a safe dose is usually around 5,000 units. Variable absorption occurs following the subcutaneous injection of heparin. Heparin does not enter the breast milk, nor does it cross the placenta. This drug is highly protein-bound to low-density lipoproteins, globulins, and fibrinogen. Heparin is removed by the lymph nodes and the spleen. With a half-life of 1 to 2 hours, that is often affected by renal and hepatic function, malignancy, obesity, presence of pulmonary embolism, and/or infection. When administered subcutaneously, heparin has an onset of 20 to 60 minutes, peaks at 2 hours, with a duration of 8 to 12 hours. When administered intravenously, the onset is immediate, with a peak at 5 to 10 minutes and a duration of 2 to 6 hours. When administering heparin, the nurse should assess for signs of bleeding and hemorrhage. The patient should be assessed for evidence of increased thrombosis, and the injection site should be observed for hematoma, ecchymosis, or inflammation. Lab values such as APTT, hematocrit, and platelet count should be monitored throughout therapy. It is important to note that the administration of heparin may cause thrombocytopenia. For patient teaching, be sure to advise the patient to report any signs of unusual bleeding or bruising. Instruct the patient to avoid NSAIDs and aspirin, and caution the patient to avoid intramuscular injections while taking this medication. It is important to advise the patient that the use of soft bristled toothbrushes and electric razors may help to prevent further bleeding. If toxicity or overdose occurs, protamine sulfate is the antidote. However, due to the short half-life of the drug, simply stopping the administration may treat the overdose. The second prototype drug to be discussed is warfarin, also known as Coumadin. Warfarin works by hindering the hepatic synthesis of vitamin K-dependent clotting factors, thereby preventing clot formation. It is used in the prevention and treatment of thromboembolic disorders such as venous thromboembolism, pulmonary emboli, atrial fibrillation, and acute and chronic blood disorders. It may be used in the prevention of clot formation following prosthetic valve placement and decreases the risk of death following myocardial infarction. Some major side effects include calciphylaxis, dermal necrosis, cramps, nausea, fever, and bleeding. A safe dose usually ranges between 2 to 5 milligrams per day. Following administration, warfarin is absorbed in the GI tract. It has the ability to cross the placenta, however, it does not enter breast milk. Warfarin is 99% protein-bound and metabolized mainly by the liver, with a half-life of about 24 hours. When administered orally, warfarin has an onset of 36 to 72 hours, peaking at 5 to 7 days, and a duration of 2 to 5 days. When administering warfarin, the nurse should assess for signs of bleeding and hemorrhage. Monitoring lab values that assess hepatic function and the complete blood count, including PT and INR, are important during therapy. The nurse should assess for increased evidence of thrombosis and monitor the stool and urine for blood before and during therapy. The patient should be educated to avoid foods high in vitamin K, as vitamin K is an antidote for warfarin. An example of this food is a green leafy vegetable. Advise the patient to avoid alcohol, over-the-counter medications, or herbal products which may interact with this medication. Instruct patient to carry identification describing the medication regimen, and advise all healthcare professionals of this medication before any procedures. The patient should be educated to use caution and avoid falls, as this medication may cause easy bleeding and bruising.
Low molecular weight heparins. The primary drug classes include heparin, vitamin K antagonists, direct thrombin inhibitors, and factor XA. These are shortened and modified molecules of heparin. Some examples include dalteparin, or fragmin, and enoxaparin, or most commonly known as Lovenox. The mechanism of action is similar to heparin, except their inhibition is more specific to active factor X. The route is going to be subcutaneously, and the dose is fixed based on the patient's weight. An advantage of low molecular weight heparins over regular heparin are they are 2 to 4 times longer in duration, produce more stable responses, have fewer follow-up laboratory tests required, and caregivers and patients can administer on themselves. In addition, they are less likely to cause thrombocytopenia. Some adverse effect includes bleeding, but they are still the preferred drug for DVT prophylaxis following surgery. Enoxaparin, or Lovenox, has a mechanism of action that includes potentiating the inhibitory effect of antithrombin on factor XA and on thrombin. The therapeutic effect includes prevention of thrombus formation. Some indications would be prevention of venous thromboembolism, or DVTs, and pulmonary embolisms in surgical or medical patients. Some major side effects include minor bleeding, nausea, vomiting, hematoma, local pain, fever, hemorrhage, thrombocytopenia, and pancytopenia. The safe dose differs based upon the use. For instance, if you're giving the medication subcutaneously for prophylaxis, you'll administer 30 milligrams every day for 7 to 10 days. If you're doing subcutaneous for treatment, you'll give 1 milligram per kilogram every 12 hours or 1.5 milligrams per kilogram per day. IV, you'll give 30 milligrams bolus followed by subcutaneous doses. Direct thrombin inhibitors. These work by binding to the active site of thrombin, which prevents fibrin clots from forming. These drugs are used until a PTT value can be received. They usually have limited therapeutic use and are only meant for temporary or short term. Some examples include Avova, Novastan, Angiomax, Pradex, and Ipravizac. Dabigatran, or Pradex, has a mechanism of action as acting as a direct inhibitor of thrombin. It lowers the risk of thrombolytic sequelae of non-valvular atrial fibrillation. Some indications include reducing the risk of stroke or systemic embolization associated with non-valvular atrial fibrillation. The major side effects include serious internal hemorrhage, hemoptysis, hematuria, sepsis, heart failure, hepatic impairment, fever, and nausea. A safe dose can range anywhere from 75 milligrams to 150 milligrams twice daily. This medication is often used to treat DVTs or PEs in patients who have been treated with parenteral anticoagulants for 5 to 7 days already. It also is a prevention of DVTs and PEs following hip replacement surgery. To reduce the risk of recurrence of deep vein thrombosis or pulmonary embolism in patients who have been previously treated, this medication may also be given.
Another drug class of anticoagulants are factor XA inhibitors. This drug class is strictly administered orally. Examples are apixaban or Eliquis, betrixaban or Bivixa, edoxaban or Cevisa, and rivaroxaban or Xarelto. Unlike other anticoagulants, factor XA inhibitors directly inhibit factor XA in the clotting cascade. Factor X is an enzyme involved in the coagulation process. These drugs are indicated for prophylaxis of DVT following knee or hip surgery. It's also used to treat DVT and pulmonary embolism, and also to reduce stroke risk and systemic embolism. These drugs are preferred alternatives to warfarin for stroke prevention due to a couple advantages. Patients taking this drug class do not need their INR monitored to determine anticoagulant effects, and there are very few drug-drug interactions, which gives patients less limitations when practicing polypharmacy. Now, there is an antidote for some of these drugs, which is called andexanet alpha or Andexa. This is approved to treat life-threatening bleeding. Factor XA inhibitors do carry a serious black box warning that extreme care must be used when discontinuing these drugs unless another drug is being substituted. Now, failure to provide an adequate anticoagulation following discontinuation may result in serious ischemic events. An example of a factor XA inhibitor is apixaban, or more commonly known as Eliquis. Apixaban is primarily used to lower the risk of strokes caused by a blood clot in people with a heart rhythm disorder called atrial fibrillation. It is also used after hip or knee replacement surgery to prevent DVT, which can lead to blood clots in the lungs, also known as pulmonary embolism. This drug is also used to treat DVT or PE and to lower the risk of having repeat episodes. This drug blocks the activity of certain clotting substances in the blood by acting as a selective reversible site inhibitor of factor XA, inhibiting both free and bound factors. However, it does not affect platelet aggregation directly, but it does inhibit thrombin-induced platelet aggregation, and it decreases thrombin generation and thrombus development. Side effects include easy bruising, unusual bleeding of the nose or in the nose, mouth, vagina, or rectum, bleeding from wounds or needle injections, and bleeding that will not stop. It could also cause heavy menstrual periods in women, headache, weakness. A patient who are on this drug may experience lightheadedness. Serious side effects include urine that looks red, pink, or brown, black or bloody stools, coughing up blood or vomit that looks like coffee grounds. Recommended safe dose for adults is 5 milligrams twice daily.